Bangladesh Lung Foundation. And we also have educational partnership with Incepta and United Hospital. So for this, we know that pulmonary hypertension consists of 1% of the global health in problems of cardiac issues, but cardiology faces a lot of problem with it as the mortality is so high. And that's why we need to all know about this, when to send patients, as the symptoms are pretty much same as any disease of heart or lung. So that's where we run into trouble, that we face the patients late. However, I will have expert presentation from Dr. Chaudhry Hafiz Ahsan. But before that, I would like to know about the pulmonary hypertension group in Bangladesh. We have two mentors here from Bangladesh who are working in BSMMU, where we have this beginning of this pulmonary hypertension group. So I would like to invite Dr. Minhaz to talk about how did they come up with this idea and how they have organized this, or pulmonary hypertension group in Bangladesh, and what are the challenges they're facing, so we understand the scope of pulmonary hypertension in Bangladesh. Thank you, Dr. Minhaz.
Thank you very much, Dr. Giti. It's a pleasure to get this opportunity and to talk before you. I'm thankful to Dr. Tasbir. He has invited me to join, and definitely all the organizers, especially I came to know about you, Dr. Giti, Dr. Aisha, Chaudhry Hassan, and everybody, all the organizers. In fact, we have organized this pulmonary hypertension clinic few years ago, and at Bangabandhu Sheikh Mujib Medical University, in order to provide proper diagnosis and treatment, what I should say, for these unfortunate patients. And then eventually a support group has been formed, which we call Pulmonary Hypertension Support Group. Department of Cardiology, Rheumatology, Respiratory Medicine, Internal Medicine, especially these four departments, we are all together working for it. And recently, it was 10th June 2023, we organized our first scientific seminar in our premises at BSMMU, and it was a hybrid type program, although most of the participants joins in person, and only Dr. Tasbir, he joined from USA virtually and delivered his lecture, and it was an excellent lecture, and we all enjoyed his talk. For our support group, I must say that the key department here is Department of Cardiology, and the key person in our group is Professor Chaudhry Meshkat Ahmed. Currently, he is also chairman of the Department of Cardiology, and we are very happy that today he is with us. And for the support group, he is a great inspiration. It is what I should say, with his relentless effort, we are trying to do some good works. And, patients in Bangladesh, especially with pulmonary hypertension, diagnosis is difficult. Delay in the diagnosis and definitely proper treatment is a big challenge. And different disciplines like rheumatology, cardiology, pulmonology, even hematology, hepatology, the patients are going to these different groups, different group of doctors. And so what we did in our program, we also invited faculties and residents from all these groups. And we had lectures and especially case-based interactive sessions. And I must say we are satisfied with this program because we got a lot of feedback, and everybody were happy with this program. If we say for rheumatology, in rheumatology, currently I am working as the chairman of the Department of Rheumatology, BSMMU, and also president-elect Bangladesh Rheumatology Society. So in our perspective, look what I said, these patients, we may belong to any group, like 1, 2, 3, 4, anywhere. So patients have immense sufferings, we find, and so early pickup and early diagnosis is always a challenge. And then what we do, we take the support from our cardiology colleagues. Mishkat Bhai is here, and he will tell, I think he will also take a few minutes to describe our activities, and also our pulmonary group is here with us. So our goal is to increase definitely the awareness of this condition for the patients as well as caregivers and as well as doctors, because doctors are even are not aware about this condition, the pulmonary hypertension. So awareness among the doctors also an important issue. And now we are only, we have limited activities in BSMMU, but we are trying to extend our activities to all over the country. And we have limited abilities, and what Dr. Aisha was telling, I'd like to request her that there are opportunities to work here also in pulmonary hypertension. So with these few words, I think I should conclude now, and Professor Mishka can tell something for us also.
Thank you very much, Dr. Minhaj, Chairman of Rheumatology in Bangabandhu Sheikh Mujib Medical University. This is a big step to start, and even here, we don't have a lot of centers that deals with certain type of pulmonary hypertension. So it's an entity in growth in progress. Next, I would like to invite Department Chair of Cardiology, Dr. Chaudhry Meskat Ahmed from Bangabandhu Sheikh Mujib Medical University to talk about his clinical experiences and how he's managing with this pulmonary hypertension support group for his patients. Thank you.
Thank you for inviting me. Actually, this is my dream day. I never had even could dream to be with all this dignitary from United States. Truly, it's a great privilege. Actually, the story started with Minhaj when he had his patients with rheumatoid arthritis and those group of patients who had the pulmonary hypertension, and nobody had were there to look after those patients. And I personally thought that these are the people actually, if we can really detect them in their early phase of pulmonary hypertension, would be the group of patient would be more benefited. So that is how we really started, because we knew the limitation in our resources and many other limitations. But we started going with pulmonary hypertension clinic, basically to support Minhaj. And from the very beginning, we have excluded the group 2 and group 3 pulmonary hypertension group. And our main focus was group 1, which is the treatable portion. As an echocardiographer, actually, I have to make many diagnoses of pulmonary hypertension. That is why the people actually center around me all over the country. And I never had been that good clinician, but for pulmonary hypertension, we really had to start this. Echocardiography, it's all right with the echocardiographic component of the pulmonary hypertension. We also have started doing cardiac catheterization for this group of patients, because we really have to mark the main pulmonary artery pressure in between 20 and 25 to get maximum benefit for those group of patients. And at the same time, I feel that our people, our cardiologists in this part of the world, in Bangladesh actually, we are less acquainted with the hemodynamics parameter. And our students and colleagues are really not that much familiar with the hemodynamic because coronary angiogram, angioplastic raise almost occupies our cath lab. So it was one of my intention that the cardiologist of our country will be little acquainted with that hemodynamic. And now today, when we had that conference on pulmonary hypertension, we included 6 disciplines. And surprisingly, those are the people from hepatology. They first started to say that this is for the first time we know that there is portopulmonary hypertension. And I said, look, you are looking forward for having pulmonary hepatic transplantation, and at least a few people from that group will be benefited most if they have their pulmonary hypertension treated before the transplant. So there are few scopes that we could found that we can really serve some of our patients from different group of pulmonary hypertension, and we really looking forward to have more armament to make a diagnosis. We in our conference also invited the director for Institute of Nuclear Medicine so that they can start the VQ scan, which is not really being done in this part in our country. And she has promised that she is going to start it. That is how we are actually moving slowly, but hopefully we'll be at some point someday. Thank you.
Thank you. And I think with collaboration with all the societies, and we also will be interested to go and contribute together and exchange ideas, and will be a big success. And with further ado, we will start our main program today. Before that, I want to mention the names that who will be in the panelist, and introduce our main speaker, Dr. Chaudhry Hafiz Ahsan. Our panelist today is Dr. Minhaj Rahim Chaudhry, who is you already heard from, Department Chair Rheumatology in BSMMU. And then we have you, Dr. Chaudhry Meskat Ahmed, Departmental Head Cardiology in BSMMU. Then we also have from Bangladesh, Dr. Ziaul Haq, Senior Consultant, Department of Pulmonology, Evercare Hospital, Dhaka. And then we also have Dr. Mohammad Shafiul Islam, Assistant Professor and ICU Coordinator, NIDCH. We also have Dr. Aisha Shikhtar, and Professor of Medicine and Pulmonary in University of Pike College of Osteopathic Medicine. And we also have, lastly but not the least, Dr. Tasbirul Islam, Chairman, PHA, and Clinical Associate Professor of Chicago Medical School, Rosedale Franklin University, and Indian University School of Medicine. So we welcome you today for our program for non-group 1 pulmonary hypertension, practical considerations and prognostic implication. Today's lecture will be by Dr. Chaudhry Hafiz Ahsan. I was asked to introduce him, but reading his short bio, I could not make it any more shorter, so I will just mention few things. Yes.
Maybe I can start. It's already getting late.
No, it's okay. Clinical Professor of Medicine, Program Director of Cardiovascular Disease in Kerkorian School of Medicine, University of Nevada, Las Vegas, and also Director of Cardiac Authorization. I have to mention few things. First of all, he's an excellent academic physician, and he wants to share his experiences everywhere through PHA, Bangladesh, and where he's working. And he has he's in the editorial board of Journal of World Heart Federation. Also, as a clinician, he is excellent with a lot of his contribution here and abroad and in Bangladesh. As a social worker, he has contributed, and he's the founder president of Sure Care Healthcare Initiative to bring healthcare expertise and services in remote Bangladesh. And, being governor of American College of Cardiology, Nevada chapter, many more things that I can say, but I will go to the lecture now, as per Dr. Hafiz Bhai saying. Maybe we can read your short bio one second later on. Thank you, Dr. Hafiz.
Thank you, Adiba. That was a very kind introduction. This is a very learned group. So I'm going to share some thoughts, and then maybe we can come up with some idea, and we'll be happy to do whatever it takes to help to develop the pulmonary hypertension program in Bangladesh. And I do agree that the hemodynamics in the cath lab is a little bit not so well done in Bangladesh. And I think we need to understand and do better. Let me share a patient, 66-year-old, with a previous surgical aortic valve, and now suggestion of heart failure with infective endocarditis. We found that the patient may have some mitral valve perforation as well. The patient is known to have COPD asthma and uses inhalers and an ex-smoker. So we did the cath, and the angiogram showed that the coronaries are fine, but we did right heart. And let me explain the right heart to you. The right atrial pressure was elevated. RV pressure is very high, and the PA pressure 95/46, and then pulmonary capillary wedge pressure is high. Peak cardiac output index is a little low, and then SVR is high, and look at the pulmonary vascular resistance was high. So the question is, in this kind of patients, there is high transpulmonary gradient. I'm going to go over the definitions in a minute. So the diastolic, PA diastolic and wedge gradient is also high, more than 7. And then pulmonary transpulmonary gradient is high. So this is not just from the left heart passive pulmonary hypertension. This has also what we call the reactive pulmonary hypertension. If you look at the cartoon here, as we develop this, see this development of pulmonary hypertension in these kind of patients, when the right heart pressure goes higher, either passive or reactive, and the vascular resistance go high, it becomes a challenging thing that whether this patient will benefit from the mitral valve replacement. The pulmonary function test actually came out okay. FEV1 FVC ratio was not prohibitive. Patient did get the mitral valve, and subsequently patient did well. This is another patient, and you are talking about the portopulmonary hypertension. This is a patient with cirrhosis, critical AS. There is a history of COPD asthma, and then FEV1 FVC was less than 70, and there was a concern for the lung function test going through the surgery. So we did the right heart cath. The PA pressure is elevated, not as high as we saw before. But if you look at the diastolic pressure gradient, is virtually none, and there is no significant transpulmonary gradient. So all these were from the aortic stenosis. And we therefore went ahead and did the TAVR, and then post-TAVR, the valve looks good. Trans-aortic gradient was less than 5, and then the PA pressure calculated by the Bernoulli equation from the tricuspid regurgitation velocity was around 40. So this is the thing that we are learning more and more, that this consequence of the left heart diseases, either from the mitral stenosis, mitral regurgitation, mixed mitral valve disease, LV dysfunction, the aortic stenosis, aortic regurgitation, all these can have a toll on the right side. And the more we see that, there can be a passive pulmonary hypertension, or there is a reactive pulmonary hypertension mixed picture with the increase in pulmonary vascular resistance, ultimately giving an increased afterload to the RV. RV may fail, and then we will get the worst prognosis. This is a publication in JACC exactly telling that if you look at the all-cause death versus all-cause bad outcome, death, stroke, hospitalization, stage 4, when clearly the right side is heavily involved, then we see the worst outcome. So what we then have to do, we need to learn, or I would say relearn, pulmonary hypertension. It is common and very common. And if you look at the global distribution of pulmonary hypertension, vast majority is actually cardiac or pulmonary cause, vast majority. And if you look at the developing countries, only very small that you are talking about the purely group 1 will fall into this, the vast majority. So we really need to tease out what is the pulmonary hypertension definition, how it applies to my patient, how much the cardiac etiology contributing, and how much the pulmonary contributing. Patients do not read textbooks. They may have multiple pathologies, and they come to us with multiple pathologies, and we need to tease out that. So number-wise is a huge burden for the world, right? And a small number also falls into this group 4, chronic thromboembolism and pulmonary hypertension. It is important to identify those. We should have the technology to identify, diagnose, give, and I'll have some slides showing whether we can give some therapy that may improve the pressure, but really much more intervention needed. Rheumatic heart disease is still a big problem, and congenital heart disease, and that can leave a brand on the pulmonary hypertension and lead to the bad outcome. So if you look at worldwide distribution from Europe, Africa, Australia, the dominant 2 factors still remain the cardiac and the chronic obstructive lung disease, chronic airflow disease, rather than the group 1 pulmonary. We know that. But a little bit of history. This gentleman from Germany, Dr. Romberg, initially mentioned about the pulmonary arterial changes similar to the systemic artery or the coronary artery. And then this gentleman, Dr. Ayerja from Argentina, mentioned that patient dying from the RV failure, and that actually inspired Dr. Werner Forsman, who is an urologist, did his own right heart catheterization, made history, and then in conjunction with the cardiologist, Dr. Cunard and Dr. Dickinson, Richard, got the Nobel Prize in Physiology in 1956. So those are the 3 big milestones. 4th milestone, I would say, that there is the development of these medications that now we can use for pulmonary arterial hypertension. And some in the group of other groups like pulmonary hypertension from the COPD, and then CT, chronic thromboembolism, pulmonary hypertension may benefit. We don't know yet. So these are the World Pulmonary Hypertension Symposium Forum. They sit in time to time. Next one is in Barcelona. But I would request you to look at this whole premises of joining together forces to see whether we can do. And there are 3 main pathways and 3 different drug developments are there. And when we discuss about group 1 pulmonary hypertension, maybe we can focus more on that. But for this group, I don't need to reemphasize the definition. But when we do the right heart catheterization, we look at the mean pulmonary arterial pressure and then the capillary wedge pressure. Cath lab, although in many ways we call the Supreme Court, but sometimes cath lab, we need to understand that we have flaws also in terms of hemodynamics. The wedge, we may not be able to wedge properly. The calibration may not be good. So after all these limitations, still we need to pay attention to the numbers and actually try to understand by other imaging modalities and the clinical context that what is going on in my patient. Although the pulmonary hypertension, like the American Heart, changed the definition of systemic hypertension, pulmonary hypertension definition has been also, the bar has been lowered. So just to give you this definition. So when we do the right heart cath, we look at the right atrial pressure, we looked at the right ventricular pressure, then pulmonary arterial pressure. We float this one, we wedge, and we see the mean pulmonary capillary wedge pressure. I mean, this is for the cardiology fellows that, you know, large V wave or not, sometimes indicate some other pathologies in the left side, such as mitral regurg, non-compliant LV, VSD, etc. But the bottom line is these numbers, it comes from the cath lab, and we need to figure out that what is happening with the pulmonary vascular resistance. How is the RV doing against the afterload? And is the RV going to able to sustain the workload? To calculate this, we need to know the Fick equation, but also we need to know how we get the pulmonary vascular resistance calculation by this. Like the systemic vascular resistance, we need to keep the two ends of the circuit, which is the pulmonary artery and the wedge pressure, and the difference between these two ends by the cardiac output or the flow. And this is the Ohm's law. And then you can check the pulmonary vascular resistance. The World Pulmonary Hypertension Symposium group, they like to make a note that less than 3 means we have to accept that the weight resistance is going up and up. And when it is primarily all due to left heart, there is entity called the reactive pulmonary hypertension that can be present, and we call it mixed pre and post capillary picture. But if there is a contribution from the COPD, or there is contribution from the interstitial lung disease, we need to understand what is the transpulmonary gradient and what is the diastolic pressure gradient, and how much each entity is contributing. Because I can tell you, often we see the patients have multiple pathologies. So if you take that and then divide this group in group 1, which is idiopathic HIV and portopulmonary hypertension, by definition, there is no increase in capillary artery wedge pressure. Whereas in group 2, which is left-sided heart disease, the wedge pressure, the LA pressure will be high, and wedge pressure is a reflection of the left atrial pressure, then it falls into the group 2. Group 3 is the real problematic, because if you have readily an explanation for the high PA pressure, such as COPD, chronic flow-limiting lung disease, interstitial lung disease, and then you see that the wedge pressure is normal, then you may call that as the WHO group 3. 4 is exclusively the pulmonary hypertension from the chronic thromboembolism, and typically they are with normal wedge pressure. So group 3, normal wedge. Group 4, typically normal wedge, exceptions there. Sometimes there is ventricular interdependence. You may see a little bit of elevated left ventricular and diastolic pressure, but the primary pathology is chronic thromboembolism. You will see the pulmonary vascular resistance will be high in the group 4. One comment about the group 2, a significant number can be flow related, congenital heart disease, ASD, VSD related pulmonary hypertension, and eventually they may see high pulmonary vascular resistance, and even the right to left shunt or Eisenmenger's complex. 5, I will have a comment at the end of this talk, because it is really uncertain group, but many entities are there. We have our friend from rheumatology, scleroderma and other diseases can be in this group. So how much that matters, how much that matters in terms of defining the strategies, how we treat these patients. And I would say a lot. And therefore, it makes sense that we do understand the group, we do understand the hemodynamics, we do understand what is happening with the RV. Is the RV failing now in irreversible state? And then the question is what we can do to take care of these patients. And I think we need to be humble. There will be situations where we'll have to concede defeat and we'll have to address the futility of care. So I'm not going to too much going into the pulmonary group 1 hypertension that itself needs a separate talk. But as you know, the hypoxia, like anything else, is a potent vasoconstrictor. With the COPD situation and hypoxia, we believe that is a trigger. But in primary pulmonary arterial hypertension, the endothelin pathway, nitric oxide pathway, and the prostacyclin pathway, they pose a very attractive pathways to allure us to treat them in non-group 1. But we need to be careful. The vasodilation often can lead to a pulmonary edema situation. So it may be very interesting to think about their use, but we cannot use them wholesale in non-group 1 pulmonary hypertension unless we know the primary pathophysiologic mechanism. So diagnosis of pulmonary hypertension in general puts us in this situation that we need to know from the hemodynamic data that what is happening with the left side, and is it primarily a group 1 patient, or we can explain the pulmonary hypertension with normal wedge pressure by disease entities that belong to other groups? Or is it just the pulmonary capillary wedge pressure high and it is really post-capillary venous and it primarily belongs to group 2 pulmonary hypertension? That is very fundamental. Echo alone is not enough. And as you know, that the echo parameters are primarily from the Doppler velocity. It is true that Doppler does not lie, but we need to have the angle theta in the Doppler equation to be 0. Otherwise, we may not get the actual velocity and we may be wrong. And often our patients with COPD, obesity, we may not get the best views, or in really end stage cases when the RV is failing and pulmonary artery pulsatility index, PAPI, is down, the velocity will go down, and therefore it will not be able to tell us what the real pressure is. So we need to understand those flaws. And I don't need to go through this because this is a very high-powered learned group. We all know the symptoms. We all know the signs. But few things I always tell my fellows: be aware about the rare presentation of a common disease and the common presentation of a rare disease. For example, idiopathic pulmonary hypertension may present with chest pain or even syncope. So the chest X-ray is helpful, like the history physical. Always we start with that. It can show the mitralization of the chest X-ray pictures. We may see the increase in pulmonary BA, pulmonary hypertension. EKG can give you pulmonary hypertension, right ventricular hypertrophy, right axis deviation, and then ugly looking precordial ST changes. Unless we know the clinical context, this patient may be diagnosed with ischemia and then give this dual antiplatelet therapy unnecessarily, loading with nitrates and God knows what, and the misdiagnosis. And if we do suspect, and this is another board question in acute pulmonary embolism, although we do CT with contrast, but for the chronic thromboembolism, the gold standard still remains the ventilation perfusion mismatch. And then that will trigger the further workup and then see whether you need to do further invasive, such as the balloon pulmonary angioplasty. Not so convincing, but pulmonary endarterectomy is a big help and has shown some even survival benefit. We are close to UC San Diego. It is one of the best centers in the world. And we do collaborate with Dr. Kim from our pulmonary hypertension collaborative group here in Las Vegas. So if you look at this, there is a significant mortality advantage when these patients did get endarterectomy. This is a single center report from Germany with the balloon angioplasty, and they show this registry type that their survival is much better than historically worse group, which the survival becomes almost 35 to 50%. So it is a challenge because the RV, and I tell my fellows, when the RV goes down, whole cardiology goes down. And the RV is resilient, and it's 1/3 of the LV size, but RV wall thickness is small, is less, and RV cannot stand this increased afterload, and therefore RV often fails. And when the RV fails, we are in big trouble. So therefore, anything conceptually, I showed you 3 major pathways to address how to reduce the pulmonary vascular resistance and then decrease the afterload. Conceptually, it is very attractive to address this afterload with those drugs. And I showed you the prognostic value of pulmonary hypertension in left-sided heart failure. How about the pulmonary hypertension in COPD patients? This is a report a few years ago that shows that if you have pulmonary hypertension, this is the goal, like the global initiative on chronic lung disease, where they stratified the patients with severe pulmonary hypertension, those without severe hypertension and severe hypertension. Look at the prognosis overall, abysmal in over time. Pulmonary disease, and then if you look at the pulmonary hypertension, even with the sleep apnea, hypoventilation, and COPD, when the PA pressure goes high, and look, this is amazing. This is the reason I'm showing you. Even a very small number study, there was significant deterioration then observed in the survival. So I like this editorial that came out in Chest, actually, that treatment of pulmonary hypertension associated with COPD. What is needed now is well-designed randomized controlled studies to determine whether improved outcomes can be achieved in this population and which patients are most likely to benefit. But even more important, for the second sentence that Dr. Klinger said, how bad does pulmonary hypertension need to be in patients with COPD before treatment is helpful? And how severe does COPD need to be before pulmonary hypertension treatment is futile? This is an amazing kind of observation and editorial, and that's why I just brought it to your attention. So we do need to learn the hemodynamics. We use the 5 French catheters and brachial access. It is an outpatient. Patient stays for a couple of hours, goes home. I have, trained the fellows to do some techniques with the BMW wire and go with the 5 French very quickly and do the hemodynamics and understand. And then, we can even now monitor. We use this also, the CardioMEM device that can check the pulmonary arterial pressure, the pulmonary vascular resistance, and we do a quick pulmonary angiogram and then deploy the, I don't know, you can see it, deploy the sensor in the pulmonary vasculature, and then we then monitor this the pulmonary arterial pressure changes from home. We are doing this in our heart failure patients and also in the end-stage renal disease dialysis patients for their full volume status. And we monitor them and record them and advise the patients as an outpatients basis. So if I may finish, because I just rushed a little bit, but it is already about 11 o'clock in Bangladesh. We need to pay attention when we are dealing with pulmonary hypertension. And we need to ask ourselves, are we dealing with pulmonary arterial hypertension or pulmonary hypertension? However, there is an overlap. And if you look at the group 5, sometimes you may be scratching your head because some of them are actually mixed pre-post capillary hypertension. But I think the best thing we have is the patient in front of us. Because if the patient has all left-sided heart failure, and we can readily explain the symptomatology and the hemodynamics, then that's be it. If it is a mixed picture, then we need to have a multidisciplinary approach and then talk to each other. And we learned from the COVID time. I can tell you this is a perfect example that the more we have communications between interdisciplinary dialogue, the more we learn about the patients and the more we'll be able to get more insights and more successful institution of therapy. So I'm going to stop there, but I will take some questions if you have. I'm sure that you might have some questions. I just thought that rather than giving an usual sort of overview, I share some experience, some thoughts, because I learned from Tasbir that this group would be really a high-level learned group. So I'm ready for some exchange of ideas and questions and answer sessions.
I would like to invite our panelists at this point to contribute their ideas and exchanges. And then after that, we have a quiz for everybody who is participating to see if somebody can win the headphones from us. So first, I would like to invite Dr. Ziaul Haq from Evercare, a consultant pulmonologist, to give your input or share your thoughts. Thank you.
Assalamu alaikum, Dr. Adiba. Thank you very much for giving a kind introduction. As usual, I'm always fascinated by Hafiz Bhai's talk. So it was very interactive and informative as well. As you know that I was in UK for some time, and then I recently moved to Bangladesh, and I found that pulmonary hypertension is one of the things which is very much neglected, not only among the patients, but mostly among the clinicians. As Hafiz Bhai was telling, that patients sometimes come to respiratory clinics without knowing that they may have got some cardiac condition. Same thing happens when they go to cardiac clinic. They may not know that they may have got some pulmonary disease there. But pulmonary hypertension has been overlooked for a long time, mainly because of we didn't have much things to diagnose it. Also, the clinicians actually probably we tend to forget about it because we have got so much common disease load from the patients. So COPD, asthma patients are overloaded in our respiratory clinics, same as ischemic heart disease in the cardiology clinics there. I mean, the drug-wise also now, some of the drugs are available in Bangladesh, which I found when I started working there. So I can tell that we use now sildenafil or tadalafil in Bangladesh for pulmonary hypertension. Also, we use bosentan and ambrisentan as well. In UK, I used to use sitazentan, which is not available in Bangladesh. but bosentan is widely available in Bangladesh. But unfortunately, some of us don't follow the guidelines. So we sometimes just pick up the medicine and prescribe it. I'm very happy to know that there is a pulmonary hypertension group now formed in Bangladesh, which we should collaborate more. And Bangladesh Lung Foundation is doing a great job for getting all these things. I think in future, we'll have more interactive sessions like this, where we can educate our juniors and colleagues, everyone in this particular disease. One thing I will just mention that about the chronic thromboembolic pulmonary hypertension, this is one of the things which is very much underdiagnosed in our part of the world. Unfortunately, VQ scan is still not widely available. I tried to start it in Evercare Hospital. I have spoken to the nuclear medicine department, but I still haven't managed to get this VQ scan started. I'm not sure whether BSMU does it or not, but these things make life a lot easier for diagnosing as well. Thank you very much.
Thank you very much, Dr. Ziaul Haq. I am very happy that you came back to Bangladesh and Evercare and contribute your work from UK to Bangladesh. And I now want to invite Dr. Mohammad Saiful Islam, Assistant Professor and ICU Coordinator in NIDCH, to share his experiences and thoughts. Thank you.
Thank you very much. Actually, I am very much excited to be here with you, such a learned gathering. At present, I'm working with as a pulmonologist and as an ICU specialist. Every time I am dealing with the severely ill respiratory patient, I have to deal with pulmonary hypertension. But I don't have the facilities of right heart catheterization or to diagnose the patient. Dr. Chaudhuri Hassan has presented, and in last slide he said that when we should start treating pulmonary hypertension in pulmonary the COPD, chronic obstructive pulmonary disease patient, or patient with chronic lung disease. That is a very difficult thing for us. Dr. Zia sir already told that we have limited facilities to diagnose and follow up this patient. Though recently a clinic has been run at BSMMU, this is encouraging. I think possibly in very near future it will be very much developed. Just few days back, maybe 1 week back, a young lady, 18 years, presented to us with recurrent hemoptysis and orthopnea. And after clinical and other follow-up investigation, we found that the lady has SLE, and right ventricle is very much weakened with only 35% ejection fraction. And he has bilateral lung opacities, more likely that of tuberculosis, heart failure, and some other infective sources. But we deal with the patient. We also have the patient has pulmonary hypertension, and mean pulmonary artery pressure was 35 millimeter of mercury. Every when we deal the patient, we was in a very much discomfort, because we don't have that much experience and facilities to clarify the line of treatment for this young lady. We took help from multidisciplinary team, from rheumatologists, from cardiologists, from pulmonologists, and critical care specialists. But at the end, we did not able to give a perfect best treatment for the patient. So I think this gathering is very much encouraging, and you are telling in the beginning of the session that you are eager to help the Bangladesh to develop a clinic or the facilities to help this group of people who are very much, Dr. Zia said, that is neglected and underdiagnosed. Thank you very much.
Thank you very much, Dr. Saiful Islam, for sharing your experiences. That is very sad to know that how we are seeing young people also. I would like to invite Dr. Asif Mustafa Mahmood. He is the GS for Bangladesh Lung Foundation and working as consultant pulmonologist in Asghar Ali Hospital. Dr. Asif.
Thank you very much for arranging this webinar. We are happy to partner with PHA, and as you can see, that is, I'm very fascinated, very grateful to Dr. Chaudhry Hafiz Hassan for making a very complicated thing, presenting a very complicated thing in a very simple manner, as much making it simpler for us to comprehend. We've already discussed the challenges here, but what BLF always looks forward to is for optimize maximum utilization of our limited resources by teaming up with all the relevant players. And I'm very happy that my good friend Chaudhry Mishkat Ahmed is leading this initiative. They've gone a long way. In between, we have also along with Professor Minhaj Rahim Chaudhry, the formation of the group, and we look forward. This is today, it provides us an opportunity for us to have a working group within Bangladesh Lung Foundation. My thoughts are that we usually have cells which work with relevant topics. So let's look at this challenge in a more positive way. We look forward to that, and we'll definitely interact with the champions of the pulmonary hypertension, Chaudhry Mishkat and Minhaj Rahim Chaudhry, and I believe that very soon we can move forward. As Zia mentioned, we have the medications, but to have a more detailed overview, I hope that Bangladesh Lung Foundation can contribute to this process. And I really look forward to, I would like to propose to Dr. Tasveer, this can be one of the topics we can cover in our upcoming session at your Global Health Conference. And later on, maybe we will have a few workshops to make the young generation, young pulmonologists more aware of this problem. Thank you very much for organizing this, and thanks once again to Hafiz Bhai for his brilliant presentation.
So my friendship with Professor Chaudhry Mishkat goes when we first met, 2005. We had a team working in Bangladesh from here, and Mishkat Bhai was like for echo, and we had a tech with the contrast echo, I still remember, and his focus was the echo. And my mentor, Dr. Vannon, who is in Atlanta, Piedmont Institute, he says, if you don't know echo, you don't know cardiology. And I wish more cardiologists were here to collaborate with us. But it is true that ultrasound is really, really important. It may not tell you the whole truth, but it tells a lot. Mishkat Bhai, nice to see you. And still, your passion is still there.
Yeah. The name of that lady was Cynthia Dale.
Yes.
And she grew with all the development of echocardiography.
Yeah.
Thank you. I think with all this of collaborations and exchange of ideas, you can start to implement the universal guidelines to help others and guide others in Bangladesh. I would like to invite now Dr. Aisha Sikdar, pulmonologist, and definitely always my mentors in every sort, to talk about her experiences and to share some ideas for this group. Thank you.
Thank you so much, Giti, once again. This really is a wonderful group of people, and I can think of a lot of progression in the future. Inshallah, we'll keep on working together, and we take your suggestions very seriously. So pulmonary hypertension, even in the United States, as Giti said, we struggle quite a bit because our index of suspicion sometimes is not high. And as Hafiz very elaborately and eloquently mentioned there's a variety of causes, and we do have to have a team approach. And I really congratulate today's speakers and panelists coming together. You have to have cardiology, pulmonology, rheumatology, CT surgeon, and sometimes interventional radiology. তো ওখানে বোধহয় বাংলাদেশে একটু অ্যাওয়ারনেসটা একটু পিছিয়ে আছে. The interventional radiology can make a huge difference in the chronic thromboembolic disease. There is a variety of drugs and we need to be aware of the drugs. আমার কাছে হাফিজ একটু অ্যাওয়্যার করলো সবাইকে. The definition has changed a little from the PA pressure above 25 এখন বলছে যে above 20 is pulmonary hypertension. However, treatment is not indicated unless the pressure is above 25. এখানে Hafiz mentioned all the groups. আমরা যারা pulmonologist, আমরা ওই গ্রুপটাকে নিয়ে chronic lung disease patient নিয়ে ভীষণ আমরা struggle kori. So when do you suspect that your chronic lung disease patient has pulmonary hypertension? Because it's negatively associated with the mortality, আমাদের suspicionটা রাখতে হবে, especially when they have increased hospitalization or increased symptoms. We have to have this high index of suspicion. We have to have testing to diagnose it. We have to determine the underlying etiology. And then we have to think about the interventions. যখন আমরা এই pulmonary hypertension patient can manage korbo, I just want to make everybody aware that they have to have vaccines. Their oxygen saturation or the oxygen level has to be above 60. সুতরাং অক্সিজেনের দিকে আমাদের খেয়াল রাখতে হবে. Hypoxia, as Hafiz mentioned, is the strongest vasoconstrictor. We have to keep an eye on anemia, and we have to remember anticoagulation is indicated only in certain cases. And women in childbearing age, if they have pulmonary hypertension, that's a total different group. So this is all I had to say, but I have a question for Hafiz. You talked about the right heart catheterization. So we start with an echo and we establish or we suspect pulmonary hypertension, and we have to substantiate it with the right heart catheterization. And then there is that group of chronic thromboembolism, যেখানে VQ scan, we have to remember, ওইটা আমাদের করতে হবে. When is the cardiac MRI indicated? And if I just may add a comment, sometimes abdominal ultrasound is an important tool, especially if you think about liver or portal hypertension. So Hafiz, when do you do a cardiac MRI? Thank you, everyone. It's a wonderful group.
So in many cases, first of all, you will not get someone who can read cardiac MR. And so question is, we are targeting to do cardiac MRI for myopathies or RV. Because some people, if you are a purist and look at the RV function, sometimes they said, okay, you need to do LV and RV EF by cardiac MR. But that's not needed in majority of the cases. But if there is a question about that the lung pathology does not match to explain the hemodynamics and cardiomyopathy is important, then cardiac MR can be a very good tool.
Thank you.
Thank you, Dr. Aisha. We are almost towards the end, so we have 3 more panelists to address to. Then we'll have the quiz, and while we are grading the quiz, we can answer the questions in the chat box. So now I would like to see if Dr. Meskat wants to add any more comments after this lecture. Thank you, Dr. Chaudhry Meskat Ahmed.
Thank you again. Dr. Hafiz, as an echocardiographer, actually, I meet so many patients with pulmonary hypertension. So it is there in my mind in real life, who are the people who are going to get benefit out of our pulmonary hypertension clinic. Initially, I really wanted to be with Minhaj Rahim for his patients, but now I find that almost 50% of the patients with heart failure are the patients of pulmonary hypertension. And as the evidences are coming out, that many of these patients with combined pre and post capillary pulmonary hypertension will actually be benefited with the treatment of pulmonary hypertension and vasodilatation. Actually, there are evidences which has shown that if we can fix the left atrial pressure and if we can treat the substrate disease, and thereafter we give the pulmonary vasodilator, especially the GMP pathway, then these are the group of patients actually will get benefit from pulmonary hypertension as a consequence of heart failure. And what is a burning issue nowadays for a cardiologist is heart failure with preserved ejection fraction. And many of these patients do have pulmonary hypertension of combined pre and post capillary pulmonary hypertension. And these are the group of people who, if we can treat early, we can also treat that substrate disease. Pulmonary heart failure with pulmonary hypertension has got almost 50% patient with pulmonary hypertension. And heart failure with preserved ejection fraction constitute 50% of the patient with heart failure population. So nowadays, I can see in very near future, we'll need to really address the group 2 pulmonary hypertension as a cardiologist. I'm quite impressed with Professor Hafiz. That CardioMEMS is the device that has been used in the practice of cardiology, especially if the patient can have their invasive in their implanted hemodynamic monitors there, and if we really can fix the left atrial pressure, and thereafter if we can give the vasodilator, these are the group of patient has shown will get the benefit. But I really did not know that he's working with group 3 patients with CardioMEMS and really looking at the benefit that this group of patients will have from treating pulmonary hypertension. This is quite interesting to me. I have just one question, and because this is one of the concerns that whether simply sleep apnea causes the pulmonary hypertension, and just merely treating the sleep apnea will do benefit this group of patients with pulmonary hypertension, because there are a good number of patients in my practice I find to have pulmonary hypertension due to sleep apnea. But this is what written everywhere, that alone sleep apnea, when they even causes the pulmonary hypertension, do not really need to be treated as such. And I have just one final comment about a VQ scan in Bangladesh. As I said earlier, director Institute of Nuclear Medicine said that if you get enough patient, then we can start it. And she also asked us to make an application to her institution from a different part of Dhaka cities, saying that we need this test to be done. As regard cardiac catheterization, actually, I started doing right heart catheter many days back, 1996 or 97, and I'm quite familiar with right heart failure. And we have started doing this in our BSME as a part of a pulmonary hypertension clinic. So little progress is there with pulmonary hypertension group, and hopefully we'll get more and more collaboration from you great people. Thank you.
Thank you. That's a great step, because over here in different hospitals, when I worked in community-based hospital, the cardiologists don't want to do right heart catheterization. They want the university or tertiary centers to do it. So if we could do more and more, then I don't have to send my patients an hour away to get right heart cath. I would like to ask Dr. Minhas to see if he has any more comments on Dr. Chaudhary's session.
Okay, thank you. Already I talked a lot. Just I'll take a couple of minutes. I'd like to thank Chaudhry H. Hassan for his brilliant presentation, and I personally learned a lot. I'd like to start with the talk from, I think, Shafiul. Shafiul, what he said that the patient had SLE and then eventually these things came up. So this is really what I should say, a real picture. We cannot diagnose early, and so it becomes very late to diagnose. So we have lots of diseases, especially those patients having systemic sclerosis. They may develop pulmonary hypertension group 1 as well as group 3 by having interstitial lung disease. And then we have patients SLE, and SLE patients, they may develop all these 4 groups, like group 1 definitely pulmonary hypertension, and the group 2 they may develop heart failure, myocarditis and heart failure. So it is possible. They may also develop interstitial lung disease and eventually pulmonary hypertension, and they may have associated antiphospholipid antibody syndrome, and this condition, antiphospholipid antibody syndrome, APS we call, they separately they also develop pulmonary hypertension, and this is definitely group 4. So these are the things we have to keep it in mind, and we are trying to tell our young rheumatologists, our residents, always they should keep it in mind that the patient may have associated pulmonary hypertension, and all of we know once the patient develops right ventricular hypertrophy, right ventricular involvement, right ventricular failure, so prognosis is worse. So this pulmonary hypertension support group is we are very much optimistic. And today also, I think Professor Asif Mustafa Mahmood, Asif Bhai is, we know he is a very good pulmonologist, and I think Mishkat Bhai will also agree that in Bangladesh also we can work with Lung Foundation. Thank you, Asif Mustafa Bhai. And another point I would like to mention just regarding right heart catheterization, and that is again Mishkat Bhai's credit that he's, so everybody was forgetting what he said when he was in NICBD. He started or tried cardiac catheterization at that time, late 90s. The cardiac catheterization they were doing in NICBD, but then in BSMMU we forgot, and again with his initiatives, and I must say he did a lot, he encountered a lot of problems, and probably now he can do some right heart catheter. And till now in Bangladesh, we are depending on, echocardiography. So definitely we are getting our patients mostly at WHO functional class 2, 3, and even 4. So if we can get them in class 1, and when the pressure like between 20 to 25, at that time, if we can catch this group of patients in terms of prognosis, that could be a great thing. And in treatment perspective, so group 2, 3, we are now using in our most of the patients that the combinations of ambrisentan and tadalafil, this group of patients, and definitely they are getting benefits in our experience, and the other drugs mostly not easily available, although I think selexipag is now one pharma, they have brought it in Bangladesh. This is the history. Okay, thank you very much. And the
Thank
last
you.
but not the least,
Yes.
last but not the ventilation perfusion scan. Again in Bangladesh, Meshkat Bhai told it is a big problem. Whenever we ask for this kind of investigation or some uncommon investigations, so the authority or the group, they will say whether it will be commercially viable or not. And we cannot answer that way always. so we cannot continue this thing. Thank you very much.
Thank you. I see Dr. Hafiz raised his
So,
hand.
Adiba, I just wanted to take 1 minute. Yeah,
Yes, yes.
I think it is better to train the pulmonologist the right heart cath. You know, in the BMNA conference, the speaker Rajiv came in and gave a talk. I trained him how to do right heart. He's a pulmonologist because many reasons that the cardiologists are less interested in right heart cath. One of the reasons is that you also want this vasoreactivity. It takes time. We use nitric oxide. Some places use the adenosine, but the nitric oxide is probably the best. But what you do with that information, I leave it to you. But when we do in our cath lab, and if we think that the PA pressure is high, we want to see this with the nitric oxide inhalation and do this. And it may not be available in many hospitals. That's why the cardiologists do not want to do this and send to the academic centers. Second one is that, Mr. Bhai, I just wanted to clarify, we are not doing the cardiomeme pulmonary hypertension monitoring in purely COPD. It's mainly COPD with the diastolic dysfunction. Sometimes we cannot be sure what is happening with the pressure changes, and they are getting rehospitalizations. And we are showing that they are actually, they can be prevented by giving diuretics and interventions and avoid hospitalization. In terms of mortality, we have not seen any benefit so far yet.
So I have a few more people who wanted to ask questions. Tasbih, but do you want to do closing comment or should I take the questions? And some people raised hands.
It's up to you. You decide. You're the moderator.
Okay. So we will end with Dr. Tasbirul Islam and then we'll know from and ask you your questions. Dr. Tasbirul Islam, our last moderator, last panelist for this session today, and then we'll go to audiences for their comments and questions. Thank
Yeah,
you.
maybe I lobby for Sadia because she's raising hand for a while. So if Tasbir kindly grants 1 minute for Sadia.
Sure. Absolutely.
Sadia, are you there? Yes.
Thank you. I just want to thank you so much. I know it's a very short time. I wanted to make a comment about the VQ scans, which is very difficult to get, I understand, in Bangladesh. You can ask help for, I don't know whether you do CTP, CT pulmonary angiogram or not. For CTF patients, my experience, it is very useful. You can determine a lot of disease and you can come to a diagnosis basically from CTP alone for CTF patients, particularly chronic pulmonary thromboembolic hypertension. The other comment I wanted to make following Aisha Appa's comment was cardiac MRI. Cardiac MRI is, I know in BSMME, we can get cardiac MRI. The gold standard for right ventricular function and volume analysis is cardiac MRI, particularly in patients with poor echo window, or you want to diagnose, you suspect an early diagnosis of right heart changes due to pulmonary hypertension. So in terms of CTP, that's integral to diagnose. Sometimes you can see incidental atrial septal defect, which is a cause of pulmonary hypertension as well. It is often late diagnosed. So it can give you a lot more information. Sometimes you can do a cardiac CT to just a cardiac CT to get right ventricular function, which is very, it is kind of an option for patients who cannot have cardiac MRI to see right ventricular function and changes in pulmonary arteries. So those are the comments I wanted to make.
Thank you, Dr. Tasbir Bhai. So we can go to questions.
And the quiz at the end. So thank you so much, Adiba, for having me today. And I want to thank Hafiz Bhai for a wonderful presentation. Not only the content, the timely fashion, কেমনে short কয়েক মিনিটে এতগুলি information দেয়া যায় সেটা শিখলাম আপনার থেকে. Thank you so much. It's a vast topic. I want to thank all the panelists today. আমি একটু কমেন্ট করতে চাই বাংলাদেশের প্রসপেক্টে যেটা জিয়া ভাই তুলছিল যেটা হচ্ছে আমরা অনেক মেডিসিন বাংলাদেশে পাওয়া যায় টু ট্রিট দ্য পালমোনারি হাইপারটেনশন স্পেশালি এন্ডোথেলিন রিসেপ্টর ব্লকার এন্ড ফসফোডাইএস্টারস ইনহিবিটরস কিন্তু বাংলাদেশে যেটা করা হয় যেটা হাফিজ ভাই বললেন দ্য রাইট হার্ট ক্যাথ ইজ মাস্ট বিফোর ইউ স্টার্ট দ্য মেডিকেশন সো সেই রাইট হার্টটা ক্যাথ করা হয় না করি ট্রিটমেন্ট দেওয়া হয় and we all know those medication are not good for group 2 group 3 and group 4 disease. So it's very important to bear in mind you cannot use those medication empirically unless you absolutely know this is group 1 disease. The group 1 আমরা যেটা বলি pulmonary hypertension the definition changes যেটা আয়শাপা বললো now is 20 not 25 and PVR is not 3 is 2 now. So now we'll see more and more pulmonary hypertension patient because the definition has changed now. এবং আমরা যেটা বলি globally prevalence is 1% and after the age of 65 it can go up to 10%. I'm pretty sure number will go up. We all know somebody has COPD with pulmonary hypertension or heart failure with pulmonary hypertension, their mortality goes up significantly and their quality of life compromised significantly. So it's very important to recognize. I'm very happy that Professor Chaudhry Meskat Ahmed and Professor Minhas Rohim Chaudhry actually initiated that support group, and I'm pretty sure it will go more and more and get bigger and increase the awareness. I mean, I can actually bolbo all the medication, the last medication we talk about prostacyclin pathways or phosphonitric oxide pathways or endothelin receptor pathways, those medication actually so far not indicated, as rather is contraindicated in group 2, group 3, and group 4 disease, except Risio-gut. That is medication you can use in group 4 disease. And sildenafil or nitric acid pathway medication is a mixed results in group 2 disease. It's very important to know it's still not FDA approved for group 2 disease, but it's very important at the moment that we need more studies before we say it is safe to use in group 2 disease. Like if you look at the Annabelle's trial using the Bosentan, if you look at the first trial using the Flolan in group 2 disease, actually is a negative study. If you look at the Artemis trial using the Ambrisentan, if you look at the Rise Up trial that is using the Risio-gut in group 3 disease, their negative trial is actually contraindicated. So it's very important to know it is group 1 disease before you use those medication. I know Jia bhai একটা কোশ্চেন করলো যে গ্রুপ 4 ডিজিজ যেটা ভেরি আন্ডার ডায়াগনোস ইন বাংলাদেশ ইভেন বাংলাদেশে কিন্তু ডিভিটি প্রোফাইল্যাক্সিস দেওয়া হয় না ইন পেশেন্ট আমার এটা ইউজ করা উচিত এখন এনি পেশেন্ট গট অ্যাডমিটেড শুড ইউজ দ্য ডিভিটি প্রোফাইল্যাক্সিস আর এখানে হচ্ছে আমরা বলি যে বেস্ট ট্রিটমেন্ট ইউ ক্যান অফার ফর গ্রুপ 4 ডিজিজ ইজ thrombectomy. But remember, the 40% actually not eligible for thrombectomy. The next steps will be, and then even if you do the thrombectomy, 50% remain persistent pulmonary hypertension. So in that case, the next step will be Risio-gut. That is the only treatment you can use for group 4 disease, or BPA, balloon pulmonary angioplasty. So, আমার একটা question Hafiz ভাইয়ের কাছে at the end. First of all, when the echo is inconclusive, like obese people, like big emphysema people, you're not getting good window, what do you do next? Do you just go to right heart cath at that time? Bangladesher প্রেক্ষিতে বলবো Bangladesher resource কম. And number 2, I mean বলবো যে when you do left ventricular and diastolic pressure, when you're struggling to get the right number for the wedge pressure. These two question for Dr. Professor Hafiz bhai.
So when the poor window, with two things, you need to know the LV, and we use the LVO pacification. As I pointed out, that Mishkat Bhai knows, they're definitive. You use to assess the LV. But for the RV, you can give saline contrast, and it may be an added benefit that in case there is any right to left shunt or high pressure and PFO opened up, that you can gather. These are the two tools. Except this, in rare situations where patient is intubated and not getting any window, then of course you can do a TE. But we don't do TE for this. That's the one question you asked. Then your second question was to
wedge pressure and LVEDP.
Oh, okay. So it is a practical problem when the PA pressure is very high, PA diastolic. Sometimes it's difficult to get a proper wedge. And in case you know that there is no reason to have a wedge pressure 45, because patient is lying flat, saturating okay, but you are getting a PA wedge, pulmonary capillary wedge of 45. That means it is not wedging right. And we actually take a cine when we wedge just to demonstrate that the wedge is proper wedge. In that situation, we put a 5 French sheath and get a arterial end diastolic pressure. It's very important. We are now learning a lot, because for the you know that wedge is not by any means a true reflection of left atrial, but for practical purposes, we use this as a marker for left atrial pressure. But if there is any requirement for the AFib ablation or for the mitral valve repair, we are seeing that the LA pressure, and there is a discrepancy also.
Thank you, Hafiz bhai.
And for the cardiomeme purposes, we actually do a end diastolic pressure, because we need to calibrate the sensor. So we actually do the end diastolic pressure and the wedge so that we see there is a match.
Thank you very much. Thank you, Dr. Hafiz, for your excellent presentation today. And thanks to all panelists for your valuable information and contributions. I will give out the questions for the quiz. As we look at the questions, a person is trying to ask questions for a long time. Dr. Ajit Chandra Bhadra, you wanted to share your experience and had question. And after that, I'll go to Dr. Shubhas Shubedi. Dr. Ajit.
I'm Dr. Ajit Bhadra from Sylhet. I am a general practitioner, and I also study with pulmonary hypertension. There are many misdiagnosis procedure staying in Bangladesh. Many of patients cannot diagnose properly in our higher center. I think that I give treatment about 40 patients in Dhaka city and India, Pakistan. But I think that there are many medicine not available in our country, and doctors are not capable to diagnose this disease as early as possible due to low instrument or other medical facility. So I want to share my experience. 2 outpatients are staying in Dhaka, pulmonary pressure 178. 178 is a rare patient or survived in Dhaka city. Patient name is Sadia. I share our experience. She is going to under treatment with iloprost inhaler, selexipag, tadalafil. His pulmonary pressure is decreased nowadays. But this medication, all our medication are imported by agency from India. So I can ask some question. So my teacher and senior doctor, what are the future medication are find in Bangladesh as easily?
আমি এখানে একটু বলতে পারি তোমার অ্যানসারে যে since 1995 যখন prostacyclin ইউজ শুরু হলো intravenous drip since 1995 তখন একটা ড্রাগ ছিল। আজকে আমরা 2023 প্রায় 13টা ড্রাগ we have to treat the pulmonary hypertension in different mode, inhaler, sub-Q, oral. Kintu pathways kintu change হয়নি। ওই prostacyclin বা nitric oxide বা হচ্ছে endothelin ওই pathwayতে আমরা রয়ে গেছি। কিন্তু we have 13 different medication in different forms. আমার মনে হয় আরো মেডিসিন অবশ্যই আসবে। সোটা টর্সেট বলে একটা মেডিকেশন আছে, সেটা প্রমিসিং মনে হচ্ছে, হয়তো বা FDA অ্যাপ্রুভাল পাবে নেক্সট ইয়ার অর 2। সেটা একটা মেডিসিন আসতে পারে, কিন্তু মনে রাখতে হবে গ্রুপ 2, গ্রুপ 3, গ্রুপ 4 those are vasodilator, এগুলি দিলে তাদের কিন্তু হাইপক্সিয়া বা লেফট হার্ট ফেলিওর ওয়ার্স হয়। So in making the things worse by giving those medication in group 2 and group 3 disease, it's very important that you should do right heart cath to make sure this is pre-capillary at the moment. There is a question of the pre and post capillary. সেটা হচ্ছে কম্বাইন যেটা সেটা হচ্ছে আই থিঙ্ক যেটা বিএসএমএমইউ সেখানে পাঠানো উচিত, কারণ হচ্ছে সেখানে এক্সপার্ট যারা থাকবে, এটা হচ্ছে স্টেট অফ দ্য আর্ট একটা ফ্যাসিলিটি হবে। You need to monitor those patients very carefully. So আমার মনে হয় আমাদের একটা করা উচিত হচ্ছে ওষুধ আছে বলে আমরা ওষুধ দিব তা না, we have to make a diagnosis correctly. And right heart cath যেটা হাফিজ ভাই বললেন, just not only the cardiologist, pulmonologist should know how to do the right heart cath, so that you have more people to do the right heart cath, make the right diagnosis and treat accordingly. Thank you.
Thank you very much. I'm just wanted to do an announcement. We are giving out questions, and one question will stay about 1 to 2 minutes. You can answer in the chat, and then whoever answers the most will mail you the headphone. Thank you. I have Mr. Shubhas Shubedi next raised the hand. Dr. Minaj, were you saying something?
Just I was trying to supplement আমাদের যে Dr. সিলেট থেকে প্রশ্ন করলো, so I think that Tasbir answered very nicely. So diagnosis is important. তোমার আমাদের জুনিয়র হবে নিশ্চয়ই, আমি একটু তুমি করেই বলছি। So কোন গ্রুপে উনি আছেন ওটা কিন্তু very important to treat your patient, and definitely I do agree with you, it's a challenge, and that's why we are trying to increase the awareness even among the physicians. Thank you very much.
Dr. Shubhas Bedi, your question, please. Shubhas Shubedi, sorry.
Well, thank you, Professor Hafiz sir, for your wonderful presentation. I would like to know what will the impact of downsizing the cutoff of pulmonary hypertension be? Like, will it label many patients to have pulmonary hypertension and increase the healthcare cost with vigorous investigations and workup? Or in contrast, will it help in achieving good control over the healthcare burden due to overt pulmonary hypertension by addressing well during its early phase?
Yeah, I think I will just refer to the or give the analogy with the American heart. You know, the American heart lowered down the bar for systemic hypertension. So one of the goals when the societies do this is to make people aware, and to pick up the disease early on, so that you can check the patient and intervene early. As you know, that just recognizing the hypertension or pulmonary hypertension does not mean that we need to institute therapy, but we need to be aware that there is something going on. I have one comment about the right heart cath and the PA pressure, like the troponin. When the troponin is very high, you know that the differential becomes very few, like myocardial infarction, myocarditis. Similarly, in very high, like systolic pressure over 100, or mean pulmonary arterial pressure over 55, 60, 70, your differential become very narrow. So be careful about those situations. Vast majority of the left heart pressure, pulmonary hypertension from the left heart, like a diastolic hypertension or valve disease, we don't see that high. The differential becomes very small.
Thank you, sir.
And I think the combination therapy, combining the different pathways, is something we will be seeing more and more literature coming, particularly for the group 1 pulmonary hypertension. What do you think?
হাফিজ ভাই, আমি এখানে আপনার সাথে টোটালি একমত। এখন এই যে আফটার দ্য অ্যাম্বিশন ট্রায়াল ইন 2015, আমরা কিন্তু এখন আপফ্রন্ট কম্বিনেশন সিঙ্গেল থেরাপি আর দিই না আসলে, সো কম্বিনেশন থেরাপিতে চলে গেছে।
No doubt about it for group 1. Even for the other groups, for example, in rheumatic conditions, for example, systemic sclerosis, which is the commonest disease that may cause pulmonary hypertension. Even so, the patients having, ILD, but probably the mechanism could be a combination one. The pulmonary hypertension and in systemic sclerosis patients, there are broadly two types. One is limited, one is diffuse. So in both the cases, the pulmonary hypertension is possible. So in this group of patients, in general, these drugs are recommended. So again, I would like to say in which group the patient is in. And probably I can just add one point for group 4 even. There are some newer drugs they are trying in addition to, I mean, this group of drugs in addition to Rosiguat, there are trials, although mostly are observational trials. And some trials, they found some benefits. So still we have to wait for some newer agents. And prostanoids, in Bangladesh, again, this drug is not easily available, is not, we have to bring it from outside. So it's a good one. It could be, we could use. And again, expenses is a big problem for our patients. Thank you.
Thank you. We have a winner. We have Dr. Nazifa, who answered most of the questions first and the right way. I know a lot of you answers right, but whoever answers maximum questions the first. So we have Dr. Nazifa. Dr. Nazifa, if you could, congratulations. And if you could put your address in the chat box to our Toma,
phone
she
number.
will mail you, and your phone number in the chat box. Toma will mail you or contact you. So thank you so much. With this, we will end our sessions today and look forward to more thought-provoking sessions and this very encouraging discussions we had. And thank you all.
And wait
night
for the
everyone.
Najifa to post the address. And Najifa, please post your address and phone number before we close it.
Thank you all for who are from Bangladesh joining. Already এখন কত রাত 11টা বাজে না 12টা বাজে
বা একটা 11:40
No worries,
shows
we really enjoyed it. Thank you so much.
Thank you.
Thank you very much.
you.
সবার প্রেজেন্সের জন্য সাদিয়াকে দেখে ভালো লাগলো। সাদিয়া is faculty at Brigham.
সাদিয়ার পরিচয়টা একটু দিয়ে দেন আপা অনেকে।
সাদিয়া হচ্ছে, she's an upcoming radiology, she's very young. ও actually faculty ছিল ইংল্যান্ডে অক্সফোর্ডে, রাইট? কেমব্রিজে।
হ্যাঁ আপা,
তুমি বলো, নিজের কথা বলো। We are so proud.
আমি কেন এত ইন্টারেস্টেড এই পালমোনারি হাইপারটেনশন নিয়ে, কারণ আমি যে সেন্টারে কাজ করতাম রয়্যাল প্যাপওয়ার্থ হসপিটাল, শাকিল ভাই ওখানে কাজ করেন। সো দে আর দ্য অনলি সেন্টার ইন দ্য ইউকে যেখানে সিটেফ এর জন্য পালমোনারি এন্ডার্টারেক্টমি করে, বিকজ ইট নিডস লট অফ skilled surgeons to do that. And one of the highest volume centers in the world as far as I know. So I was trained in Midland. So আমি chronic pulmonary hypertension বা pulmonary hypertension নিয়ে রেডিওলজিতে এত বেশি ছিল না আগে। আমি যখন আসি প্যাপওয়ার্থে তখন I was so surprised to see that we can diagnose so much radiologically, and it needs so much input from all disciplines to diagnose or to exclude some diagnosis, basically a radiology contribution থেকে বলতে গেলে। আমি দেখেছি ওখানে কিন্তু পালমোনারি অ্যাঞ্জিওগ্রাম যেটা ইনভেসিভ অ্যাঞ্জিওগ্রাম, ওটা কিন্তু ইন্টারভেনশন কার্ডিওলজিস্টরা করছে, রেডিওলজিস্টরা কিন্তু করছে না। So that's another thing I wanted to mention. সময় ছিল না বলে বলিনি। আর এখন আমি কাজ করছি মাস জেনারেল হসপিটালে বস্টনে। আমি রিসেন্টলি বিকাম জুনিয়র অ্যাটেন্ডিং দেয়ার। সো ওখানেও আমি দেখছি পালমোনারি হাইপারটেনশন নিয়ে অনেক কাজ হয়, বাট দিস ইজ অফটেন মিসডায়াগনোসড ফর সো মেনি ডিফারেন্ট রিজনস। সো আর আমি খুবই প্রাউড টু জয়েন পিএইচএ অ্যাজ এ রেডিওলজি লিড।
Thank you, Sadia. So happy to have you here. I'm pretty sure তোমার অনেক প্ল্যান আছে আমার সাথে শেয়ার করছো। ইনশাআল্লাহ আসিফ ভাই আপনার ওই যে BLF এর সাথে আমরা ইনশাআল্লাহ আমরা কিছু রেডিওলজি ইমেজিং চেস্ট ইমেজিং নিয়ে কিছু সেশন করব সাদিয়াকে নিয়ে ইনশাআল্লাহ সেটা প্ল্যান
We look forward to that. Already আমরা একটা session I remember she had
করেছি মে মাসে, হ্যাঁ মে মাসে করেছি। জি
আমার একটা সেশন আছে নেক্সট সেপ্টেম্বরের 3 তারিখে। আমি সবাইকে ইনভাইট করছি এখনই, কারণ এটা কার্ডিয়াক সেশন। আমি মানে মেইনলি কার্ডিওভাস্কুলার এন্ড থোরাসিক রেডিওলজিস্ট, সো আমি এটা একটা কার্ডিয়াক সেশন করছি combined with cardiologists and cardiac surgeons, just for physicians, to let you guys know what we can do with cardiac imaging, just cardiac CT, which is available in Bangladesh. So আমরা আসলে কি কি ডায়াগনোসিস করতে পারি, why it is important, why you need to use it more and more. So আমরা ওগুলো নিয়ে কিছু কেস, সরি আচ্ছা শিওর।
আমি একজন জেনারেল জিপি প্র্যাকটিস করি একটা গ্রামে। তো আমি অনেকগুলো পেশেন্ট আমার আন্ডারে আছে, বাংলাদেশের 5-7 জন, আর পাকিস্তানের আছে 4-5 জন, ইউএসএ থেকেও 2-3 জন আমাকে মেইল করে যোগাযোগ করে। তো আমি বেশিরভাগ দেখতে পাচ্ছি যে পেশেন্ট গুলা, বাংলাদেশের যে পেশেন্ট গুলা, ইন্টারন্যাশনাল যে পেশেন্ট গুলা ট্রিটমেন্ট পাচ্ছে সেটা আন্তর্জাতিক ভাবে মানসম্মত ভাবে পাচ্ছে, কিন্তু আমরা বাংলাদেশে যারা পেশেন্ট যারা, তাদের প্রেসিশন দেখলেই বোঝা যাচ্ছে যে 5-7 বছর আগের মেডিসিন গুলা এবং সনাতন পদ্ধতি গ্রহণ করে চিকিৎসা নেওয়া হচ্ছে, এজ ওয়েল এজ এমডিনসেন্টান এন্ড টাডানাফিল অর সিন্ডানাফিল, এর বাইরে কোনো ট্রিটমেন্ট পাচ্ছে না। কিন্তু বাহিরের পেশেন্ট গুলা ভালোভাবে মেডিসিন গুলা পাচ্ছে যেহেতু অ্যাভেলেবল আছে। আমাদের দেশে মেডিসিন গুলা কিভাবে অ্যাভেলেবল করা যায় সেই বিষয়ে আপনাদের কি মতামত, সেই সম্পর্কে একটু জানতে চাচ্ছিলাম।
সম্ভবত বাংলাদেশে যারা কাজ করেন তারা বলতে পারবেন, আমি তাজবীর ভাই হয়তো বলতে পারবেন।
ম্যাডাম বাংলাদেশে এই মুহূর্তে মেডিসিন গুলা যেগুলো অ্যাভেলেবল আছে, মেসিসেন্টান, বুসেন্টান, সেলিক্সিপ্যাক, ইনসেপ্টা লঞ্চ করছে 6 মাস মতো প্রবাবলি, আর নিউ আর কোন এজেন্ট আসতেছে না।
শোনো অজিত, তোমাদের যা মেডিকেশন আছে দ্যাটস ইনাফ, কিন্তু তোমাকে যেটা বলা হচ্ছে যে প্লিজ ট্রাই টু মেক দ্য রাইট ডায়াগনোসিস। আমি বলবো এখন প্রফেসর মিনহাস রহিম চৌধুরী আছেন এখানে, প্রফেসর চৌধুরী মেশকাত আহমেদ আছেন, তারা প্রাইমারি সাপোর্ট গ্রুপ খুলেছেন বিএসএমইউ, তাদের সাথে কন্ট্যাক্ট করো। They will guide you absolutely how to get the diagnosis rightly and get the medication. Medication অনেক পাওয়া যাবে, কিন্তু রাইট ওয়েতে ইউজ করা হচ্ছে কিনা সেটাই আসল। তুমি যে মেডিকেশনের নাম বলা, that's enough at the moment, কিন্তু ব্যাপারটা হচ্ছে যে are you using them in right way? That is the important question to ask.
I think we need to have a more discussion, like when you talk about group 1 pulmonary hypertension, right?
Right.
At that time we can discuss more about the medication. Sadia, we'll keep in touch. I think you are relative of Shilpi, right?
আমরা একই রুমে বসে আছি পাশাপাশি, কারণ আমরা হলিডেতে, কিন্তু আমরা এত গিকি যে we couldn't miss the session. আমরা দুজনেই শেখার চেষ্টা
সাদিয়া,
করছি।
আমি একটু অবাক হচ্ছি, ইন লস কেমনে পাশাপাশি বসে?
Sadia,
তাজবীর সাদিয়ার জন্য একটা
out of you.
সাদিয়া তোমার জন্য কোশ্চেন। হ্যাঁ
সাদিয়ার জন্য কোশ্চেন না, এটা হলো যে সাদিয়া ইজ ভেরি রাইট, কারণ আমরা ভিকিউ স্ক্যান খুব পাবো না, আমরা আসলে সিটি pulmonary angiography,
Exactly.
and there are subtle changes that really makes CT angiogram equivalent to that of VQ scan. সাদিয়া যদি আমাদের সেই subtle change গুলো আমাদের রেডিওলজিস্ট কে দেয়, তাহলে আমরা VQ এর পিছনে আর দৌড়াবো না।
I will be really glad. কারণ হলো I was so fascinated. আমি বোধহয় 3 বছর আগে শিখেছি how to look at a CT scan from that perspective, that I'm going to diagnose it. আমি এখনো আমি যে ট্রেনিং পাই ওদের মধ্যে অ্যাওয়ারনেসটা খুবই কম। Patient with shortness of breath getting lots of CTPE for diagnosis of acute pulmonary embolism, কিন্তু chronic embolismটা very I think one of the most misdiagnosed condition in radiology, কারণ আমরা CTPE দেখি, we don't look for it. If you don't look for it, the subtle changes are often missed. So but if you develop your eye, I will be really glad to participate in all these sessions, because I've got a bit of experience now. এবং আমরা অবশ্যই
দুটাই করতেছে, আমাদের পালমোনারিরা দুটাই করে, সিটি এবং ভিকিউ, বাট ফর দি বোর্ড পারপাসেস still the gold standard is VQ.
Oh, definitely. আমি যেটা দেখেছি এটা as you said এটা multimodality imaging
Yeah.
is needed. So echo থেকে শুরু echo যদি আপনি early diagnosis করতে চান right ventricular dysfunction you can do cardiac MRI. বাংলাদেশে এখন আস্তে আস্তে available হচ্ছে and then right heart catheter then you need to do CTPE CT pulmonary angiogram CTPA. তারপর VQ scan তো definitely করতে হবে. MR pulmonary angiogram is available in Bangladesh. You can do that as well to see the filling defects. Those are very subtle in CT. So often we use MR pulmonary angiogram as well. So অনেক কিছুই বাংলাদেশে করা সম্ভব আসলে if we develop the system. So I'll be really happy to join the group and talk about all these imaging findings we can share.
Giti, let's have a on the speaker.
Yes.
I just had a comment though. Tasbih bhai, Hafiz bhai, Aisha Appa, Giti Appa. I kind of thank you enough for running this whole program for years now. My good friend Saiful Islam, from I think he's from Bangabandhu. He was making a comment, and it just crossed my mind. The whole idea is exchange of ideas here. I really enjoyed this very in-depth conversation, session. But I was just wondering, he was asking, if can we organize or arrange some sessions where we can teach them, like the fellows over there, or even the faculties, like doing the heart catheterization. Even in America, I have to be honest, I'm an internist. I practice, and I always like to say that I'm an internist because I like to enjoy the beauty of medicine. But I often see that patient with severe COPD, I'm suspecting that patient might have some associated pulmonary hypertension. Going to cardiologists and going to pulmonologists, to everybody's frustration, very rarely any pulmonologist will go to that depth, or cardiologist will initiate a right heart catheterization. So I was just wondering, if we really can organize some sessions in Bangladesh in person where we can teach the right heart catheterization so that they are real comfortable and really do those things. I think that's what she was asking for as well. Thank you.
Shilpi, actually, our guys with our pediatric cardiologist guys, they are doing so many cardiac catheterization. I just forgot one thing to mention, that we have another pulmonary hypertension clinic at National Heart Foundation. It is run by Naharuma. She has got almost 500 patients, and they do this cardiac catheterization so regularly. I know it is so difficult at a time to find out the PCW. But again, people are doing this thing in Bangladesh, and our pediatric cardiologists are there to help us in making so many diagnoses, hemodynamic.
Thank you. It was good to know.
Thank you, everybody. If there's no more discussions left, we'll end these sessions today, since it's late night in Bangladesh. And I had really a lot of fun and learned a lot from all of you. As we move on, these collaborations are helping us to know the resources in Bangladesh and educate us too. Thank you very much.
লাস্ট কথা গীতি, তোমার পারমিশন নিয়ে বলছি, আমাদের PHA গ্লোবাল সামিট হবে February 23rd and 24th. আমরা ইনশাল্লাহ অফিসিয়াল ইনভিটেশন সবাইকে পাঠাবো, কিন্তু প্লিজ মার্ক দ্য ক্যালেন্ডার ফর February 23rd and 24th. is a PHA Global Summit. ইনশাল্লাহ আপনারা সবাই আসবেন, সবাইকে ইনভাইট করব। আর ওখানেও cardiology, যেটা হচ্ছে হাফিজ ভাই এবং নাসির is taking the lead. They will talk with you guys about the, যদি মনে করেন কোনো ওয়ার্কশপ on right heart cath বা pulmonary hypertension, যেখানে pulmonary group ও BLF ও participate করতে পারে। So inshallah we'll talk more and more. Please mark the calendar for February 23rd and 24th for a global summit in Dhaka, Bangabandhu International Conference Center. Thank you.
Thank you, Adiba. Thank you. You moderated very well.
Workshop sounds excellent idea. ওটা মাথায় রেখো, and you asked me a question, I'm with you all the way, এটা মনে রেখো, with PHA. আর গীতি excellent moderating, এত high profile লোক নিয়ে navigate করা খুব কঠিন। Enjoyed it.
Thank you.
আচ্ছা
Khudafez.
হ্যাঁ
Khudafez.
খোদাফেজ, থ্যাংক
সবাইকে।
ইউ, থ্যাংক ইউ, বাই।
আসসালামু আলাইকুম। খোদাফেজ।
ইসকাত ভাই, আমি অক্টোবরে আসলে দেখা করবো আপনার সাথে।
ইনশাল্লাহ।
আমি
মেশর ভাই
ধন্যবাদ।
খোদাফেজ, প্রফেসর মিনহাজ খোদাফেজ, খুব ভালো লাগলো জয়েন
খোদাফেজ,
করলেন।
খোদাফেজ।
দেখা হবে
হ্যাঁ,
ঢাকা
আমাদেরও ভালো লাগলো, এনজয় করলাম খুব।
ইনশাআল্লাহ।
Awesome.
ওকে, আসসালামু আলাইকুম। আসসালাম।